Hey guys, welcome back for another conversation. I'm your host. My name is Sing Ping. I'm a board-certified pain management pharmacist. This is one of the episodes that I want you guys to listen to the very end because I'm going to be talking about a health technology that you and I probably use every day. But most of us don't know what to do with the information that this health technology is giving us. And we probably also take this health technology for granted for way too long. If by this time you're like thinking, what the heck is this health technology then? Well, it's the good old prescription drug monitoring program. And I'm not doing this episode by myself today. I invited a very special guest. This guest has been working in the healthcare field for over 15 years. If you ever wonder how we even get to see the layout in front of us when we just click a button or go to the website, well, there's actually a person and a team that works behind the scenes so then the hospital system can connect with the PDMP data so that there is the data in front of us for us to see. Without further ado, hi Ben, welcome.
Sing Ping, thank you for having me on, and always a pleasure to collaborate with you, my friend.
Pleasure is on me. So I do not want to steal your thunder. Can you tell us about yourself?
Yeah, like you said, I've spent the last 15 years building and implementing healthcare technology solutions. I currently work with state governments and health systems across the country to deploy the next generation of medication intelligence tools, is what I call them. A big part of that is the working with the state, and they're providing the technology platform for their prescription drug monitoring program. But equally important is the integration component and making sure that the PDMP data along with clinical decision support tools are available in the prescribers and dispensers systems. So think of it as like making it easy for a provider to access this data without leaving their PMS or EMR system like Epic. But I also do a lot of work with state opioid treatment programs where we deploy a centralized registry to track enrollment status, prevent dual enrollments, and provide visibility into the dosing information for continuity of care. I think if you wanted to put it all into a single sentence, I would say that my work and the work my team does is focused on improving health data interoperability to support prescribing best practices and clinical decision making.
Thank you. What I want to tell you is we need more of that, right? Because we use PDMP all the time, and from what you were saying, you're also starting to look into treatment programs and having their data become accessible, which it's something that we may not have right now, and it sounds like it's from a very archaic regulation. And I'm glad that you and your company is actually actively looking into that, and I believe that is something going to be so important from the access standpoint and how it can reduce a lot of time doing all the manual work by calling the programs to confirm the dose.
Well, it's important work that we're doing, not just my team, but you as well, Sing Ping. So I think as rules and regulations continue to change, some of them dating back 50 years, it allows the pipes to open up and the data to flow in a more meaningful way. And our goal, and my counterparts in the field, I think we all share a goal of providing a more holistic view of the patient to the clinician at the point of care when they're in the room with them.
Speaking of holistic view, today you and I are going to be doing something very interesting because we're going to be doing some role playing, and we're going to look at holistically at the PDMP data. Today, you're going to be the second year pharmacy resident. So I've been told that I am a very harsh preceptor. Just kidding. Are you ready for that challenge?
I think I'm ready, but take it easy on me, okay?
I will try. So Ben, can you give us a debrief on the first case for today?
My pleasure. First case is Mark Hendricks. This is a 96-year-old male who has stage 4 prostate cancer that's metastasized to the bone. The patient was brought into the emergency room because his spouse found him to be a bit more confused than usual. Looking at the PDMP here, Sing Ping, what are some red flags that you're seeing in his current regimen?
That's a very good question to start. Let's break this down into pieces so then I can walk you through how I can make sense of all these data here. So the first thing that I'm going to be looking at is what kind of medication is the patient currently filling right now. we can see right off the bat the patient is feeling fentanyl patch and MS content, which is another term for a long-acting morphine. Every time we see something like a long-acting opioid, we have to be extra cautious, just because from my experience, things tend to go wrong very easily when patients are on long-acting opioid. Now, if we take a step back and take a look at the proximity of when things are being filled, that will give us another angle of what kind of things could have gone wrong here. Let's look at the date fill for all these medications. You can see that the patient just got a fentanyl patch, and then 10 days ago, the patient got a 30-day supply of the long-acting morphine. And something we should pay attention to is that the patient also got a Xanax here. So every time we see what we call a benzo opioid combo, that should be another red flag we should be catching, because we know from research that that combination is very prone to overdose. So from the medication itself, the proximity, and also what kind of medication the patient is feeling, that already gives us a lot of information. Something I also want to point out here, which is a very nice feature, is that you can see here there is an alert telling us that there is an overlapping prescription. So looking at how the dates and how things are very close to each other, and also there is the opioid benzo combination. So this flag right here, the visual and the color, gives us a very nice alert to alert us to pay extra attention to what's being filled here. Finally, I also want to point out, when we are looking at prescription drug monitoring program, we're not just looking at the medications, we're not just looking at the date. We also want to take a look at who are prescribing these medications, because if patient were to go one prescriber to another, that is sometimes a problem. So let's take a look. You can see that when the patient was receiving the long-acting morphine and the Xanax, it's from one prescriber. And then when the patient was receiving the fentanyl patch, that's from another prescriber. So somehow down the line, the patient might have switched prescriber, or maybe there is another doctor taking over the case. That can lead to the confusion that we are seeing at the emergency room. And also a quick comment on this layout is that we don't really see a NARC score, which is something that I've seen in other platforms before. My experience using NARC score is that that score doesn't really tell us a lot of detail, and what I've seen is that it aggregates some of the risk, but we never really know how that score is actually being calculated. And instead of relying on a score, I always tell my students and residents to look at the raw data instead of relying on just an arbitrary score, even though there might still be science backing it. But knowing the very basics on PDMP interpretation is very important.
Yes, Singping, your assessment here is correct. So first of all, in the solution that we have here, the RxGov platform, we stay away from opaque risk scores, but we want to deliver clinical insights to the provider that are accurate to the patient. So, a couple things. I really like that you noticed the red flag for an overlapping drug class, the benzo and the opioid scripts that are overlapping. But another thing I liked is that you're not completely relying on the clinical decision support tools. You're actually looking at the data. And so one example of that being, we've got another alert tile up there for multiple prescribers and multiple pharmacies. That's not triggered, right? It's green. And the reason for that is these alerts are really, the thresholds are set at the state level usually, and that could be more than 5 providers triggers the alert, more than 3 pharmacies triggers the alert. That's a customizable feature. But even when you only have 2 providers, it's still important to go and look and see, hey, there's multiple people that are part of this patient's care, uncovering why they may have 2 separate opioid prescriptions at the same time.
And that is a very good point, because being able to identify what's the changes that happened recently is going to be a very good conversation opener with the patient, because if you go into the room blindly, then patients would feel like you didn't read the chart. But if you go into the room knowing how things are being evolving, and when you phrase your question in a way that signals you read the chart, that's going to help you build rapport. If you want to build rapport with your patients quickly, you always want to pay attention to all the little details that is in front of you.
Yeah, great point. So, Singping, what kind of counseling would you provide to the patient or to his spouse upon discharge?
Now that we have identified that the patient is receiving two opioid in a very close time period, something that I like to tell patients is what we call a safe disposal, because if we find out that the patient is indeed only be using fentanyl instead of using any more of the long-acting morphine, we want them to dispose of them safely. We know that sometimes when we have the opioid medication, unused opioid medications at home, there might be incidents where the family members may take it, or maybe little kids can have access to it, that can cause an overdose. Things can happen. So we want to give them some counseling on safe disposal. There are bags and there are bins that you can place them, or you can even bring them to the police department for safe disposal as well. The other thing is that we want to give them what we call the overdose counseling, because I think in this day and age, we probably watch too much YouTube and dramas that when we think of overdose, it's like you just somehow drop dead on the floor, which is really not the case, because there are symptoms before the overdose can happen. For example, patients will start to snore louder than before, or the patients will their hands will start to get clammy, or the patient would start to get really sleepy, and in some cases where their lips and their fingernails and fingertips would start to turn blue and gray. And those are the things you need to tell them, because those are the realistic signs that they need to be watching out for. And the last thing that I also like to share with patients like this when they are navigating different kinds of opioid regimen, especially with new changes, I like to have them do a pain diary. And it is a practice that I share with not just patients who are having any new medication changes. I like to tell a lot of my chronic pain patients who have been on medications for a long time to keep a journal, so then they can see how are things working out for them. Is there any kind of triggers that will make the pain worse or better? And how is the medication lasting? Like, is it lasting for 2 hours? Is it lasting for 4 hours? And it is also a very good exercise for them to document if things are going wrong. For example, how is maybe like if they start on an oxycodone 5 milligrams and a 10 milligrams, how is a 5 compared to a 10 in terms of side effects? So by keeping a pain diary, that will help the patient visualize and document what's going on. And from a clinician perspective, that is also something very concrete, that if they let us review and read the same note together, then it is a very good way to have very conducive conversation on what's going on and what are the changes. So in the last case, we looked at a case where there are multiple prescriptions that can cause problems. And in the next case, I think it's going to be also something very interesting that has to do with buprenorphine. So Ben, can you give us a debrief on the next case?
Let's look at Miss Peg Carter. This is a 77-year-old female who just had a knee replacement. The doctor prescribed a 5-day course of oxycodone for post-op pain, and when the patient went to the pharmacy to pick up the prescription, the pharmacist was a little apprehensive to fill it. Singping, from your experience, why would a healthcare professional feel apprehensive when they see a PDMP record like this, with the patient just there to pick up a post-op opioid prescription?
I'm glad you're asking this question because this is still some questions that are rather unfortunate because of the stigma and our lack of understanding on buprenorphine that will lead to the apprehension that we are facing. So if we look at the medication and look at the PDMP again, we know that this time around what we're looking at is this medication called buprenorphine. In this case, because buprenorphine has so many formulations, we are specifically looking at this one called the Suboxone. And kind of following a very similar format of how we look at the PDMP, we see that the patient is filling the Suboxone. And looking at the date, we also saw that the patient is pretty consistent in filling their Suboxone. Now, one of the reasons why the clinician may feel apprehensive when dispensing the post-op opioid for this patient, over the years, I've had different experiences and heard different reasons for that. Part of that is because we know that for Suboxone, one of the indication is for opioid use disorder. And sometimes when the clinician see that the patient is filling Suboxone and they just assume that the patient has opioid use disorder and they just feel like the patient should not be using any additional opioid, and which is false because we know that when patients are on a stable dose and the patient also have proof on the PDMP that they are filling the Suboxone consistently, if they are post-op, they should be receiving additional opioid for their pain. There's a lot of research that has been done for that. If we do not know that the buprenorphine, or in this case Suboxone, can also be used in some off-label pain indications, we just assume that the patient is using the Suboxone for opioid use disorder. That lack of understanding of how the buprenorphine works and how it's being indicated, that can be a reason why the clinician feels apprehensive about dispensing the oxycodone for post-op.
So what can the pharmacist or a clinician do to ask or alleviate some of the concern here?
I know that buprenorphine has such a learning curve, especially when I first started, but now there's so many good resources out there that can help you learn buprenorphine. And I think from a working knowledge standpoint, with buprenorphine, I think any provider should know at the very bare minimum that buprenorphine is not just for opioid use disorder. It can also be used for pain, depending on the dose. A little golden nugget and clinical pearl I would like to share is that look at the dose when we are looking at buprenorphine. If the dose is dosed in microgram, mcg, then most of the time it is for pain. And if the dose is written in milligram, mg, then the indication can be either opioid use disorder or off-label for pain as well. So by recognizing what dose range is for what, that is the very first step I would give any students and residents to really help them orient what kind of indication are they looking at. So kind of going back to this case, when we see that the dose of the buprenorphine is in milligram, the first thing that we should be asking ourselves is, can this patient be using Suboxone for pain instead of opioid use disorder? Even if they have opioid use disorder, it's just opioid use disorder. It's a chronic disease, just like hypertension and anything else. And if you are not sure, you can just ask them, hey, I see that you are on this medication called buprenorphine or Suboxone. And I also see that you are picking up the oxycodone. Did you talk to your doctor about this additional medication you're about to pick up? That will help prime the conversation, and instead of assuming that the patient is having any kind of problems, you're actually opening the conversation and have a discussion of what's going on. That's what I like to tell my residents and students on how to handle and navigate buprenorphine. Ben, thank you for being my resident for the last 30 minutes. How are you doing? Pulse check.
Oh, I think I'm doing just fine. You weren't as tough on me as I thought you'd be, Sing Ping.
So before we wrap up, I do want to ask you some questions on PDMP, knowing that you really are the person working so closely on PDMP and with facilities that use PDMP. So what do you foresee PDMP to be in the next, let's say, 2, 3, or even 5 years?
Give me a magic wand. There's a couple of things that I'd like to see, and I'd like them to happen a little faster than they are now. But one being a broader adoption of like HL7 fire standards. The goal is to make interstate data sharing more consistent, giving the clinicians a more reliable longitudinal view of the patient across state lines. Some of that has to do with data sharing agreements from state to state, but in a perfect world, you've got all 52 PDMPs that are sharing data with one another. So you've got true interstate data sharing and can see the full view of the patient no matter where they're receiving care from. I think another thing I'd like to see, and we touched on it a little bit, Sing Ping, was better clinical decision support. So thank you for highlighting the RxGov alert tiles. It's great to have alerts for your MME average, your multiple provider, multiple pharmacy episodes, and overlapping drug classes. We talked a little bit about risk scores, and I think what I'd like to see more than anything, if there are risk scores that are today a little bit opaque that are being used, the ability to click or launch into those and see exactly what made up that risk score, rather than just providing a score, and clinicians, they sometimes feel like they have to base their decision making for that patient off of that score. Nothing against the scores themselves necessarily, but I think it's really important for a provider to be able to look into whatever score is presented and see what actually went into arriving at that score, right? It's probably some of the things we talked about, overlapping drugs, multiple providers, MEs, those are things that probably go into it, but if there are other criteria that make up that score, I think it's critical for the clinician to be aware of those things. They're ultimately making the decisions for the patient's care. Another thing I'd like to see in the future is the inclusion of behavioral health and opioid treatment program data in the PDMP. There's been some federal changes to 42 CFR Part 2 that are paving the way for a more holistic view of patient care by integrating that formerly siloed data. For those not familiar, 42 CFR Part 2 is really about patient consent, and it was put in place decades ago when there was a higher stigma around substance use disorder. And so, as those rules continue to evolve, really would like to see that opioid treatment program data, which has been excluded from PDMPs due to privacy regulations, increasingly be integrated into PDMP data. So if a patient's going to a MAC clinic and receiving treatment, and you as the pharmacist or the clinician don't have access to or visibility to that data, it could affect the way that you, or the drugs that you prescribe, or potential drug interactions that may happen. So future systems, in a perfect world, will include modules for direct communication between providers and pharmacists, as well as links to social services or treatment networks, turning the PDMP into a hub for warm handoffs to addiction specialists. And then if I could have one more, I would say more PDMPs, more states to ingest all medication data, not just controlled substances. I think, the controlled substances are certainly the most important for the PDMP today, but in a perfect world, we're giving you visibility into the entire patient medication history, so you can make more informed decisions as a clinician on what you're prescribing.
I love the idea of having access of, let it be methadone or other medications. If patients are receiving methadone at a clinic, and then sometimes that is really hidden from the PDMP, and if I have access to that would make my life so much easier, because I would make less phone calls in my day, because that process usually take me at least 15 to 20 minutes of the back and forth, and even getting getting them to be on the call, and it's even more problematic if it's overnight when they're actually closed. So that would be a huge step that would be like a gospel for me. And I also want to share that if one day we are going to have all medications almost like a centralized platform with the power of AI, I feel like that would give us a lot of information, and in the future for if we're using it for research purposes. So I feel like that would be something that is very bold and very innovative. So thank you for sharing.
Oh, thank you for the opportunity, Sing Ping.
And really, thanks, Ben, for being so kind to be my guest today and also being my mock second year resident. I really enjoyed our conversation today, and thank you so much for being here today.
Thank you, Sing Ping. I enjoyed it as well. We'll do it again sometime soon.